Appendicitis is a global disease. It is characterized by the inflammation of the appendix. The leading cause is due to the blockage of the appendiceal lumen by substances like hardened stool, mucus, appendicolits, appendiceal tumors, intestinal parasites, bacterial obstruction, or enlargement of lymphatic tissues. The mechanical obstruction of the appendiceal lumen can trap naturally host aerobic and anaerobic bacteria like E. coli and Bacteroides species, leading to their overgrowth, which result in acute inflammation as well as abscess formation. The risk factors and epidemiology of appendicitis include age. It is commonly occurs between the ages of 10 to 30, with a peak incidence in early adulthood. However, it is rare in infants and older adults, but tends to be more severe if it occurs in older adults. As for genders, males are slightly more likely to develop appendicitis than females. The lifetime incidence of acute appendicitis is 8.6% in males and 6.7% in females. Lifestyles and dietary habits in which high in processed foods or low fiber diets associated with constipations and fecally formation, which increase the risk of obstructions. Infection by the bacteria in the gut can trigger the inflammation of the appendix. Family history as well as formation of tumors or abnormal growth may increase the chance of getting appendicitis. Family history suggests possible genetic predisposition, while tumors block the appendix and create condition for an infection.
Next, I will present the histopathology of appendicitis, which progress through 4 main stages, starting with acute appendicitis. Under the microscope, we observe mucosal ulceration with neutrophils infiltrating the submucosa and muscularis propria. The lumen contains necrotic debris and hemorrhage, and the serosa shows inflammation. Reactive lymphoid hyperplasia is often seen. At higher magnification, we can visualize a pus-filled exudate and widespread inflammation, although some glandular structures remain intact. The key of histological changes include epithelial erosion, transmural neutrophilic infiltration, vascular congestion, luminal exudate, and inflamed serosa. Pathogenesis typically begins with luminal obstruction caused by fecalith or lymphoid hyperplasia. Mucus accumulates, intraluminal pressure increases, and vascular compression leads to ischemia. This sets the stage for bacterial overgrowth, ultimately resulting in progressive inflammation. Now, moving to suppurative appendicitis. At low magnification, we see diffuse infiltration of neutrophils extending across the entire appendiceal wall. At higher magnification, dense neutrophilic aggregates are visible, often forming small intramural abscesses. Areas of necrosis and early tissue breakdown are also apparent, especially in the muscular layer. Histologically, suppurative appendicitis is defined by the infiltration of neutrophils into all 3 layers of the appendix. As the inflammation spreads through the full thickness of the wall, it can result in ulceration, the development of intramural abscesses, and even vascular thrombosis. These changes indicate that the inflammation has progressed from localized mucosal involvement to complete wall destruction. Grossly, the appendix appears enlarged with a poorly demarcated serosal surface. Surface vessels are congested, the lumen is dilated, and the serosa is covered by a thick fibrinopurulent exudate.
Next, we move on to the gangrenous appendicitis. In this case, the key feature is transmural coagulative necrosis, which is the mucosa, submucosa, and muscle layers all lose their structure. Neutrophils infiltrate the full thickness of the wall, and blood vessels are of full thrombus and hemorrhagic. For pathological changes, the primary pathological process is severe ischemia, which is leading to the infarction, and this also comes with loss of tissue integrity and toxin production. And for the histological changes, we can detect the loss of mucosal structure, coagulative necrosis, and also thrombus vessel in submucosa. Lastly, we move on to the perforated appendicitis, where in this case, the serosal layer is disrupted, and this indicates the full thickness of wall necrosis. We often see pus and necrotic debris spilling into the surrounding tissues with sign of early peritonitis. For pathological changes, the perforation allows the leakage of luminal contents into the peritoneal cavity. This followed by abscess formation and also sepsis risk. And for histological changes, we can see the serosal rupture, accumulation of debris, pus, and also disorganized tissue structure. Pathologically, both result from luminal obstruction and ischemia. Gangrenous change reflect vascular compromise. Perforation result from sustained pressure and tissue breakdowns. To summarize, gangrenous and perforated appendicitis show severe progressive destruction and appendiceal tissue, is highlighting the importance of early diagnosis and surgical treatment.
Now, we will discuss about the clinical implications of appendicitis. Early symptoms include abdominal pain experienced initially around the belly button for several hours. As the pain intensifies, patients will develop nausea and vomiting. The nausea will later stop and the pain will be more focused at the lower right abdomen. Patients will also lose their appetite because of the cytokines released in response to the inflamed appendix, which affects satiety regulation. Additional symptoms include fever when the body's inflammatory response is too high or when the bacterial infection has spread. Some patients also experience diarrhea as the inflamed appendix irritates the colon. Since appendicitis is a medical emergency, one possible complication if the appendix is not removed immediately is that it could burst and lead to peritonitis that must be treated quickly or can lead to death. If burst appendix occurred, even when after that it is removed, there will be abscess formation in the belly and the pus will have to be drained by surgery.
Diagnosis of appendicitis involves three main steps, which are clinical assessment, lab test and imaging. First, in clinical assessment, doctor asks about symptoms and use physical signs like McBurney and Blumberg. McBurney sign involve pressing a specific spot on the abdomen, which is like about 1/3 from the hip to the belly button. Tenderness here suggests appendicitis. Blumberg signs, on the other hand, check for rebound pain. If pressing and releasing the belly causes pain, it may indicate inflammation. Next, lab tests such as blood test is done to look for elevated white blood cell and C-reactive protein which signal infection. Urine tests also help to rule out other diseases that may make the appendicitis symptom like urinary tract infection or kidney stone. Finally, imaging tests help to confirm the diagnosis. An abdominal ultrasound is used especially for children and pregnant women as it avoids radiation. CT scans offer high accuracy and are very helpful in detecting an inflamed appendix.
Moving to treatment for appendicitis, antibiotics such as ampicillin, gentamicin, and metronidazole is used in early uncomplicated cases or as pre-surgical prophylaxis. When using this three combination of antibiotic, we must close monitoring. 70% to 85% of patients might success, but recurrence might occur. In advanced and complicated cases, the surgically remove of the appendix is required, which is known as appendectomy, is a gold standard. It divides into two, which is laparoscopic surgery and laparotomy. The laparoscopic is the preferred, and appendectomy indicates in all suspected acute cases, especially if worsening. The outcome and prognosis of treatment: when the patient have early treatment, it might get full recovery, but if delayed diagnosis, the patient might perforation, abscess, and sepsis. Mortality is rare if managed quickly. So if perforation is occur, the patient may require drainage, IV antibiotics, and have the risk of peritonitis and abscess.
Now, I will explain on the ethical consideration. The first ethical issue is biopsy handling, which include patient-informed consent for biopsy procedure and storage. Next, the quality and integrity of the sample. Maintaining the quality and integrity of the biopsy specimen is an ethical requirement for accurate diagnosis and research result. This involves proper collection, fixation, processing, and storage to avoid degradation or contamination. Lastly is necessity. The collection of tissue should be restricted to what is required and necessary for diagnosis and treatment. The second ethical issue is patient confidentiality. These include data security, where pathology lab handle highly sensitive patient data, which require reliable system to provide data integrity and protection. Next, reporting and communication. When reporting histopathological result, care must be taken to ensure that sensitive information is transferred securely. Lastly, patient data should be de-identified or anonymized to protect the identity of the donor. The last ethical issue is the medical research on appendicitis. This includes the use of archival tissue for research. Using existing appendectomy specimen for studies on the appendicitis research can be ethically sound if proper informed consent was initially obtained. Next, beneficent and non-beneficent in research design. Research on appendicitis histopathology should be designed to maximize the scientific benefit and minimize any potential risk to patients whose samples are used. Lastly, transparency and accountability. Research and institutions must be transparent about their research objective and method, including adhering to ethical guidelines.
In conclusion, appendicitis remains a common and urgent medical condition, most prevalent among individuals aged 10 to 30 with slightly higher rates in males. It arises due to obstructions of the epidential lumen, leading to bacterial overgrowth and acute inflammation. Histopathological findings, including neutrophilic infiltrations, vascular thrombosis, and tissue necrosis, to support diagnosis and staging. The diagnosis involves a combination of clinical signs, blood urine tests, and imaging, such as CT or ultrasounds. Treatments and strategies range from antibiotic therapy in mild cases to surgical removal via appendectomy in more severe or complicated presentations. Delayed treatment may result in perforation, abscesses, or sepsis, highlighting the need for early intervention. Ethical consideration in biopsy handling, data privacy, and responsible research are critical in improving care and maintaining public trust.